Okay, so I guess many of you are wondering how can we assess pediatric oncology nausea and vomiting mainly. There are several tools that we can use to assess the nausea and vomiting in pediatric. All of us know that nausea and vomiting is something that's very subjective to the patient, even in adult patient. So in pediatric, we have a pediatric nausea assessment tool and Baxter-Ritchie phases scale, and the name is still that so we had. Many of you are wondering how can we assess pediatric oncology nausea and vomiting. There are several tools that we can use to assess the nausea and vomiting. Sure. Okay. So there are several tools that we can use in pediatric nausea and vomiting to assess the extent of nausea and vomiting after receiving the cycle. We have a pediatric nausea assessment tool and Baxter-Ritchie face scale. And that, as you can see here, that it's resembles the Wong-Quaker pain scale. So the pediatric had to express his feeling after receiving the chemotherapy by selecting the phase that he can. And hopefully we're gonna hear Dr. Sameh insight about using his tool in pediatric populations mainly, in his project, I mean. So as I said, it consists of the survey that it's a selected age of patients mainly. It's begun from 4 years old pediatric till more older than 8 years. It's consists of the survey that you can ask the patient about nausea and vomiting using the family term to express his feeling after receiving the chemotherapy mainly. So understanding the risk factor is something very important, because if we adjust the risk factor, we can improve the patient experience after receiving the chemotherapy. So the extent of hematogenicity with the chemotherapy is important, while the patient-related risk factor is very important, and the radiation therapy in line with the chemotherapy as well, that I will not be covering in my slide today. So there are many prospective and retrospective studies evaluated the patient-specific risk factor from, gender, age, prior history of the chemotherapy-induced nausea, vomiting, or even psychological factor. However, this study has a very limited pediatric number in that study and have incomplete definition of acute or complete response to the antiemetic mainly. So as you can see here in the table, female more than 5 years old exposed to the chemotherapy before have a poor performance status is one thing that we should consider while prescribing the antiemetic prophylactically to the patient mainly for the chemotherapy. So moving to the chemotherapy or drug-specific risk factor, you can see here that the highly hematogenic drug or chemotherapy with a high dose, or even the intensive protocol, especially in pediatric as the ALL or neuroblastoma protocol, have very intensive chemotherapy. So those kind of patients, you should consider reviewing the antiemetic before prescribing the next cycle for them. So it's important to highlight the classification of antiemetic potential of intravenous and even oral. I know that adults have 2 levels for oral, while in pediatric we had 4 levels for oral and intravenous mainly. So the highly hematogenic, it's associated with more than 90% will have experienced nausea and vomiting if you did not give them the right prophylaxis or antiemetic, while the minimum is less than 10. I will not go in details for each drug classification or about each class and the chemotherapy of it. So as you can see here, there's a classification for highly hematogenic chemotherapy. is considered to be classified to single agent and combination agent. I just want to draw your attention that Irina, at a dose of 25,000 per meter square, international per meter square, are added to the recent update in 2019, while the combination of cyclophosphamide and doxorubicin and then actinomycin is considered to be highly hematogenic. The same principle apply in moderate and low hematogenic chemotherapy and minimal hematogenic chemotherapy as well. So moving to the most important part of my presentation is the guideline that we use to prevent acute and delayed nausea and vomiting in pediatric by using pediatric oncology group recommendations mainly. There are three major classes used in chemotherapy-induced nausea and vomiting prevention. The first class is serotonin antagonist, corticosteroid, and the neurokinin receptor antagonist mainly. So if you had a patient who will receive a highly hematogenic, first you have to divide the patient to dexamethasone permitted or dexamethasone contraindicated patient, because there is some indication that you can't give dexamethasone to that patient. So if your patient is dexamethasone permitted and his age is more than 6 years old, and there is no potential drug-drug interaction with aprepitant or NK receptor antagonist, you can give serotonin antagonist and aprepitant and dexamethasone. While the patient is less than 6 months, because we had age limitation in using NK receptor antagonist, and had drug interaction that will interact with aprepitant mainly, you can use the long-acting serotonin or serotonin with dexamethasone alone. For a patient who is the contraindication is the corticosteroid, is contraindication. If his age is more than 6 months and there is no potential drug-drug interaction with aprepitant, you can use aprepitant plus long-acting serotonin. While the patient is less than 6 months and have a potential drug interaction, the drug of choice here is the long-acting planocytron. The same principle apply for moderate, but for the patient who had like dexamethasone contraindication, we can add aprepitant if the patient is more than 6 months and have no drug-drug interaction with aprepitant mainly. For the low hematogenic, you can use the first generation serotonin antagonist mainly, the ondansetron or granisetron, while the minimal hematogenic, no routine prophylaxis are recommended. So to manage patients who come to you with delayed nausea and vomiting, first we have to prevent the acute nausea and vomiting by proper selecting the antiemetic prophylaxis to begin with, and we have to evaluate the cycle. So the most common chemotherapy that associated with the delayed nausea and vomiting is cisplatin, cyclophosphamide, and doxorubicin. Dexamethasone and NK receptor antagonist is considered to be effective in preventing and managing patients with delayed nausea and vomiting, and you should consider scheduling the steroid and NK receptor antagonist as aprepitant for 2 to 3 days after the chemotherapy. For breakthrough nausea and vomiting, first, before discharging the patient to home, you have to add one of other class medication as a PRN medication, and ask your patient if he had any experience of nausea or vomiting to add this medication to his home medication as around the clock, that's a PRN medication. So if the patient had still nausea and vomiting, rotate the drug within the same class or rotate the scheduled medication. Don't rotate the road because it have the same effect mainly. And at the end, note the patient specific changes for the next cycle. So you can add these medication that you added already as a PRN as a regular medication for the next cycle. And you should evaluate your patient every 2 days. If the patient is uncontrolled, we have to rotate and switch or schedule the medication. But to manage patients with anticipatory nausea and vomiting, to date, there is no special study for using benzodiazepine in pediatric as to control nausea or anticipatory nausea and vomiting. But according to the CAOG protocol, they continue to recommend using lorazepam or alprazolam at a low dose, 2 doses before the chemotherapy. And the most common or the most important principle of anticipatory nausea and vomiting is to control the acute and delayed nausea and vomiting. And we have to watch the adverse effect as the sedation and amnesia and hypotension. So there are 4 phases that's important in chemotherapy-induced nausea, vomiting in pediatric: acute and delayed, anticipatory, and breakthrough. Each phase had a specific drug that we should use to prevent the nausea and vomiting mainly. So to choose the anti-emetic or to properly choose the anti-emetic for your patient, your choice should be based on the anti-emetic risk of the therapy and prior experience with anti-emetic, patient factor, potential drug interaction, as I said in aprepitant. So let's move to the last part of my presentation, the pharmacological review of anti-emetic. In early 1960 till 1990, we don't have anything unless we had like a high dose of metoclopramide and dexamethasone. Then in early 2000, we have planicitron, aprepitant was approved in pediatric. So after that, we can have an overview of the aprepitant story or journey mainly. So in 2011, the first phase 3 pediatric aprepitant trial was started. In September 2015, the FDA asked for the pharmacokinetic data in patients age less than 12 years old and the body weight is more than 30 milli. And in December 2015, the FDA approved the oral suspension for the patient who are aged more than 6 months. After that, the aprepitant oral solution was commercially available. So let's talk about the first class, NK receptor antagonist. Aprepitant and phosphoaprepitant is the only NK receptor antagonist that is approved in pediatric. It's competitively antagonize the NK receptor at CNS mainly. It's used to prevent acute and delayed nausea and vomiting. No hepatic or renal adjustment are required. So aprepitant was approved based on the phase 3 randomized controlled trial, where they randomized patients from age 6 months to 17 years to aprepitant ondansetron arm and placebo ondansetron. They found that the aprepitant arm had a complete response in terms of delayed and acute onset and overall, and both groups have the similar adverse event mainly. So in 2014, that was our standard of care in pediatric mainly. No aprepitant unless the patient is more than 12 years old. The new standard of care is to use aprepitant in patients more than 6 months, and for a patient who had highly hematogenic or a patient is or the patient with moderate hematogenic and the dexamethasone is contraindicated. There is several, highlight that I want to highlight in the special consideration that aprepitant is CYP3A4 inhibitor and substrate. So we have to look to the drug-drug interaction. Either it's pharmacokinetic drug interaction or even possible adverse event resulting in some of the adverse effect as a phosphomide and aprepitant mainly. It is the pharmacokinetic data for the NK receptor antagonist. I will not go in details with it. I just want to highlight that the aprepitant and aprepitant is not FDA approved for pediatric. Moving to the second group is granisetron, or serotonin receptor antagonist.
2 minutes, please.
It's block the serotonin peripherally and centrally. The oral medication is effective as well as the IV. And beyond use of these medication for 48 hours, there is no any more benefit or effective. So here is the doses for granisetron for highly hematogenic chemotherapy and moderate, and it doesn't require any renal or hepatic impairment or adjustment. I just want to highlight that granisetron is carry some of QT prolongation. It may cause QT prolongation, so you have to review your patient profile mainly for any drug that can cause QT prolongation as well. Moving to the second generation, which is planicitron. It's in 2014. It was approved for pediatric age more than 1 month to 17 years. It had longer duration and higher affinity to receptor of, the serotonin receptor mainly. And here is the dosing, and it was approved based on multi-center double-dummy trials mainly. Here is the pharmacokinetic data for serotonin receptor antagonist. Just want to highlight that ondansetron is not FDA approved for pediatric yet. Moving to the third major class, which is the corticosteroid. to date, the mechanism of action is unknown, but we believe that it inhibits the prostaglandin system in the cortex, and it has a special dosing in highly hematogenic and moderate hematogenic chemotherapy. I just want to highlight that if you use the aprepitant with the patient on dexamethasone or corticosteroid, you have to reduce the dose by 50%. And we have also to omit the dexamethasone for any patient who is receiving steroid in the chemotherapy protocol as lymphoma or leukemia, or any patient who is receiving a CNS chemotherapy for CNS malignancy, as we believe that it could decrease the permeability of the chemotherapy to the brain. It's contraindicated in protocol that utilize the immunological biological therapies, and the major side effects hypertension and bradycardia and hypokalemia and insomnia and gastritis. So that's why we should consider GI prophylaxis with dexamethasone. Moving to the fourth class, it's a typical antipsychotic, which is olanzapine. It's not yet in the protocol. The mechanism of action is directly antagonizing the CNS, the serotonin, dopamine, and H1 antagonist. The recommended dose is 0.14 milligram per kg once daily. The maximum dose is 10 milligram as an adult, and that was based on randomized open label phase 3 trial in pediatric. The trial revealed that olanzapine achieved the complete response for acute and overall period and delayed period. And the patient who received the olanzapine had no nausea and vomiting, and it was significantly, the p-value was significant, statistical, clinical and significant p-value mainly. The last but not least, I can see that it's not gold, that the metoclopramide, which work as inhibiting the dopamine at a low dose, while the high dose metoclopramide can inhibit the serotonin mainly. In 2015, the FDA approved, the black box warning for metoclopramide. It associated with extrapyramidal symptoms in children at the recommended dose. That's why we use diphenhydramine to prevent these adverse effects. Here is the doses based on pediatric oncology group. So according to the last updates, it's used only for breakthrough nausea, vomiting, not at the first line. And it's need a renal dose adjustment mainly. So in summary, we need to gather information about the onset, frequency, severity, and the predisposing factor. And we have to determine the type of chemotherapy-induced nausea and vomiting. Is it acute? Is it delayed? Is it anticipatory? And we have to determine also the fluid status of the patient and the drug-drug interaction. So the decisions of choosing the antiemetic is based on the formulation, because we know that pediatric, we had a lot of concern about the presence of the formulation at an institution. Also the age and weight limitation, the adverse effect that the patient may have with the use of these antiemetic mainly, and the compelling indication. Take-home message: the chemotherapy-induced nausea and vomiting have a negative impact on patient compliance, patient family, and patient quality of life as well, and the management plan. Understanding different pathophysiology and chemotherapy-induced nausea and vomiting and drug hematogenicity are key to select appropriate antiemetic drugs. The use of assessment tool will facilitate for further research, and we will know the efficacy of our antiemetic, as we are aiming to minimize and control the chemotherapy-induced nausea and vomiting in pediatrics. Antiemetic drugs should be tailored according to the patient risk, and the high incidence of breakthrough. We hope that we don't see it a lot in pediatric with the new, more effective medication as aprepitant and plancitron. And thank you.
Thank you, Dr. Atika, for the elegant presentation. First, we're going to check over the web if there is any questions. Can you help me, Dr. Majid? Okay, it seems no question over the web. The first question will be directed to Dr. Fatma. Dr. Fatma, in practice of pediatric hematology oncology, when we have a chemo order written by the consultant, it goes to the pharmacy for processing direct. Some hospitals are implementing that the clinical pharmacist should sign the order before it goes to the pharmacy, either before the consultant or after the consultant. Can you comment on this practice? And are you implementing this in your hospital or not?
Thanks for the question, Dr. Mohammed. I think that this practice is a good practice because we see different aspects of chemotherapy other than the aspects seen by the physician. But this is not implemented in my institution. The physician is usually it's been entered by assistant or specialist and double checked and signed by the consultant.
Yes. The second question to Dr. Sameh. You know the tumor lysis syndrome, one of them is hyperphosphatemia. When you have a patient with high phosphate, you start with aluminum hydroxide first, while you go to sevelamer direct. What is the dose of aluminum hydroxide that you usually use, and the frequency, I think, is important in this regard.
As per the guideline that I shared, we usually start with sevelamer and its dose based on the age. We don't usually use aluminum, especially if the patient, most of our patients are moderate to high risk. We would start with sevelamer first.
Yeah, and also when you have a patient with G6PD positive, how do you decide to give rasparequase to these patients?
We don't usually. Obviously, we do G6PD deficiency up front before we, as part of the routine lab with the patients with their leukemia panel. And unfortunately, I haven't had any patients with G6PD deficiency that needed rasparequase, but obviously, you have to make sure that you deal with from the hydration perspective and making sure the patient is monitored and you don't get them overboard to the point where they actually do need the rasparequase. I think upfront management of the hydrations and making sure albuterol is optimized and probably easing the chemotherapy, in which case sometimes we do with lymphomas where we do like a pre-phase and then we do the actual chemotherapy just to minimize the lysine to give the kidney sometimes. Like we talked about before, if you have somebody with good renal function, technically speaking, you should not develop TLS unless you overwhelm the kidney with such a high amount of lysine of the cells, be it leukemia or lymphoma.
Thank you, Dr. Sameh. Third question to Dr. Atika in regard to the management of nausea vomiting in children. And I think from my feeling that the control of nausea vomiting in children is inferior to those in adults. Do you agree with me on this notion or not? يعني we are not so careful tailoring the anti-emetic protocol to the chemo protocol in children compared to the adult.
Yeah, because I don't think that we have a very standard for the pediatrics. We had some pediatric that received cisplatin with any nausea, there's no incident nausea vomiting with cisplatin, or we had patients receive cisplatin and have a very significant delay in nausea. So the pediatric variability in the pharmacokinetic that give us
So you agree with me or not?
Yeah, to some extent.
Two settings. طيب, any question from the great audience here? Dr. Fuad, تفضل. Microphone, please.
Assalamu alaikum, Dr. Kumar here.
I have one question only for the Dr. Atik about the pediatric dose. If you have a pediatric obese patient, are you giving the antibiotic as a standard, as a maximum one, like for ranitidine, or you are giving for the calculated by kg for this patient? Just like, thank you.
We always go with the maximum. Pediatric adult maximum dose, so you get 1 milligram.
Can you raise the voice, Dr. Atik?
We always give the pediatric the maximum adult dose, so we don't exceed 1 milligram. Although there is a Japanese study, they studied the dose of 3 milligrams as maximum for ranitidine, but we believe that ranitidine already saturated the serotonin receptor, so there is no benefit to add more dose and add more toxicity as well.
Thank you, Dr. Fahd.
This question also for Dr. Atik. So the interaction between the aprepitant and the ifosfamide, I know it's like a category X kind of interaction in vaccine, but on the adult side, we know from practice it doesn't really happen frequently, so we still give aprepitant with ifosfamide. What's your experience with the pediatric population?
We never use it with ifosfamide because of the significant interaction.
Okay.
Any further questions? Dr. Majid?
Thanks, Dr. Muhammad. I don't have questions, but I have comment on the 2 points. The first point was about the interactions between aprepitant and ifosfamide. I think in adult, because I was involved in the incorporation of the chemo, building up the chemo protocols, we use healthy aprepitant with ifosfamide, and we, in the past, like can say, 10 years of my practice, I never we never reported any case of CNS complication with this combination. Only one case was, I guess it was with hematology team. That patient had CNS complication, but we're not able to say that this is due to the side effects because the patient has, I think, CNS infiltration of the leukemic cells. This is the first comment. So the conclusion of this comment is that I'm very, I can say I'm very comfortable to combine aprepitant, especially with sarcoma to cause methods. I cannot, ifosfamide is used with high doses in sarcoma, so I don't want to ignore my patients and not giving offering them aprepitant. The second comment about the respiratory use with the 6PD deficient patients, we had experience with one of the lymphoma patients who was admitted. Unfortunately, the screening was not done for that patient and ended up with ICU admission with hemolysis. The hemoglobin dropped from the normal range, you can see more than 10 to reach to 5 or 6, and this was unfortunate. So now the G6PD is a must for all patients with, especially lymphoma patients.
Great, we have to be very careful with our patients, especially when applying knowledge to the patient care. Dr. Atika, the last question I have about the ballonicitron. You know, this drug came in the maybe 5 years ago, 6 years, and then everybody want to get it. The price was huge compared to the other medication. So many hospitals declined using it. So what about your hospital? Can you comment on that? You don't have it. Yeah. I remember King Faisal, we tried to add it, but it was very expensive. What do you think, Dr. Majid? Combination. For adult. Is it very effective?
It is.
Yeah, very good. Okay, we conclude this session. Thank you very much, Dr. Noura.
Thank you everyone for attending our first session for today, and we would like to thank our speakers and moderator for the first session. We have here Dr. Majid Shimrani, who's going to hand them their certificates. Our moderator for this session, Dr. Muhammad Ashur. دكتورة فاطمة الحداد. دكتور سامح حواد. الدكتورة عاتكة الهربي. We would like to conclude our first session, and we will be back after 15 minutes break, inshallah, with our second session. Thank you.